This lecture focuses on endocrine pathophysiology, that is, abnormal secretions of hormones and the consequences of such conditions. As we have learned that there are a long list of hormones, the abnormalities associated with each and every one is going to be different, and we need to be able to understand how the lack of or too much of a certain hormone would affect the body. Okay, so here we will focus on the basic definitions, like what is hyposecretion, what is hypersecretion, what is primary hyposecretion, what is secondary hyposecretion. And then once we understand the vocabulary, we will talk about hormones that are released by the hypothalamus and pituitary. So that would be our focus in this video. In the subsequent videos, we will talk about abnormalities related to thyroid gland or adrenal gland and so on. All right, so let's get going. We would focus on the definition of primary hyposecretion. Hypo means under secretion, okay? Less than normal amount of a hormone released. Primary tells you that the gland that's responsible for the secretion of a hormone is not functioning, and therefore there is less than normal amount of hormone released. In comparison with primary, you could think about secondary. Secondary is where you have yet another structure, another mechanism that's affecting the function of this endocrine gland. So it's not the gland itself, the gland is fine, but you're talking about another hormone that's needed in the release of hormone from this particular gland. Okay, so there are examples I have used here. Hashimoto's thyroiditis is where the thyroid gland is affected by the autoantibodies. Okay, so there is reduced thyroid hormone secretion. Whereas in secondary hyposecretion, let's think that there is a tumor in the pituitary gland, that is where it's not able to release TSH in the normal levels, and therefore it's not able to stimulate the thyroid as much to make its hormones T3 and T4. All right, so the same rule applies to primary or secondary hypersecretion. Think about hyper, where it's too much of a release of a particular hormone. Okay, too much hormone released by the gland is primary hypersecretion. If there is another force that's making the gland produce more than normal amount of hormone, that would be secondary hypersecretion. Good. With this definition, we're ready to talk about antidiuretic hormone or vasopressin. It's abbreviated as ADH. Antidiuretic hormone, vasopressin, is actually secreted by a group of cell bodies that are situated in the hypothalamus. Supraoptic nucleus is a particular section within the hypothalamus. That's where the cell bodies of these neurons are situated. And then their axons actually terminate in the posterior pituitary. So the production is in the hypothalamus, release is from the posterior gland. When is it released is basically repeating physiology. The hormone secretion is when there is increased osmolarity of the blood. Okay, so reduced volume, reduced fluid, and that may make the solid concentration to appear as if it's too much. So greater osmotic concentration of the blood is sensed by osmoreceptors in the hypothalamus, and therefore hypothalamus would then release more vasopressin. All right, so that is the normal condition: decreased blood volume, blood pressure, increased blood osmolarity, and that causes secretion of ADH. And when ADH is present, what does it do? That is the action of ADH. Okay, antidiuretic hormone uses calcium mediated. Calcium serves as the second messenger system here. That's the mechanism that's used by ADH at the renal tubule. These tubular cells would now be able to bring more water from the filtrate back into the system. So reabsorption of water increases in the presence of ADH. And ADH also causes vasoconstriction, and that is how we can reverse the situation that is increased blood volume and increased blood pressure. Now that's all normal. Here we want to consider abnormal conditions. What is that abnormal condition you want to talk about? There is, for no reason, less ADH being made, less ADH being available to maintain normal function. Okay, so that's one situation: less hormone available. A lack of response to ADH is also another possibility. So there are two situations. You may have normal levels of ADH, but kidney tubules may not respond to this ADH. So that is what you call as nephrogenic type. If kidneys don't respond, but we have sufficient amount of ADH, that is nephrogenic, meaning the problem is at the nephron. Neurogenic or central diabetes insipidus is where it's not being made in sufficient amounts. There is less than normal amount of ADH present. Okay, so yet another condition related to ADH is too much ADH release. Okay, if you have too much ADH release, that is the condition you call as syndrome of inappropriate ADH secretion. All right, syndrome of secretion of inappropriate ADH, SIADH. Okay, so those are the two conditions that we want to talk in detail. Okay, so let's focus on diabetes insipidus. That is where you have low levels of ADH. Okay, that's because the neurons are not making enough ADH. Okay, what is the cause of that is all going to be discussed next. And what happens in the absence of ADH is the immediate question to ask. Because there is not enough ADH to bring water back into the system, most of it is lost in the form of urine, polyuria. Okay, frequent urination, and urine output typically is 1 to 2 liters, but now it has gone up to 8 to 12 liters per day. Polydipsia, all right, because you're losing so much water in the form of urine, the body simply turns on a thirst mechanism to compensate, and that's how there is increased desire to drink water. Okay, so there is this constant thirst. And because of the loss of water, the plasma osmolality would be greater than normal. As you may or may not No, the fluid osmotic concentration in the body typically is about 290 milliosmol, but here it would be greater than this number. Okay. Now, as I mentioned before, there are two types: neurogenic or central diabetes insipidus, where you're releasing less ADH. Nephrogenic diabetes insipidus is where you have normal amount of ADH, but the kidney tubules are insensitive to ADH. Okay, and it says collecting tubules. ADH action is typically in the last part of the tubule. This is the distal tubule, and then the collecting duct. Okay, those are the places where the cells are not responsive to ADH. All right, so either condition, we will talk about the causes here. Head trauma is one common cause, or surgery of brain, where there probably is some injury to the hypothalamus, or lesions. There is destruction of the tissue in this particular part where ADH is made. Those are all causes of central diabetes insipidus. Lithium intoxication. This is a drug that we use for bipolar disease treatment, for example. So too much lithium can cause the kidney tubules to become insensitive to ADH, and that's what you think could be the cause of nephrogenic diabetes insipidus. As we discussed before, polyuria, nocturia, meaning you get up many times in the night to pee, all right, and continual thirst. Low urine specific gravity, because there is so much more water than usual, the specific gravity is now less than normal. Okay, it is diluted. Solutes appear to be less because of the additional fluid. A low urine osmolality. So the blood osmolality would be higher, whereas the urine osmolality would be lower. Okay, hypernatremia, too much sodium in the blood, not because you ate a lot of sodium, you brought a lot of sodium into the system, but because you're losing water, and the main ion in the blood would be sodium. It appears like it is greater in its concentration. Water deprivation does not change urine osmolality. Okay, so this is where you can use this as a testing method. What if you drank less water? Would that change urine osmolality? No, because you're not able to retain fluid. You're letting it go, whether you have been drinking or not. So it's just losing more and more water. Okay, so urine osmolality would not change when you bring less fluid. It's just to assure that it is to do with ADH. Okay, it's to confirm that it is diabetes insipidus. Now, what are some clinical signs and symptoms? Altered mental status, seizures, fatigue, weakness, hemodynamic instability. All these are associated with this low fluid hyperosmotic condition of the blood. Treatment for neurogenic, you know that there is less ADH than normal. You need to replace ADH. Synthetic vasopressin analog, desmopressin, DD-ABP is what is given. Nephrogenic is where you may want to treat the condition that's causing it. All right. How does this affect your role? Well, you need to be monitoring urine output, because there is so much of it, and in an hourly fashion, measure serum electrolytes and plasma osmolality. Dehydration makes it more sensitive to the hypotensive effects of anesthesia agents, so that is another caution you have to take. All right, so now let's turn to talk about syndrome of inappropriate secretion of ADH, SI-ADH. Okay, here you're talking about excessive secretion of ADH, opposite of diabetes insipidus. Okay, so opposite types of signs and symptoms is what you want to think about. Hyponatremia, less than normal sodium ion. Why? Because you're bringing more and more blood back to the system, more and more water back to blood, and therefore the blood is diluted. Hypoosmotic, not hyperosmotic. Got it? From the expansion of intravascular fluid volume, secondary to hormone-induced reabsorption of water. Okay, you're bringing more water from the kidneys into blood, and the expansion of the intravascular fluid volume. So there is more blood volume than normal. Got it? What causes it? Ectopic production of ADH by tumors. That's very common cause. Okay, and a couple of tumors that are very common are small cell lung carcinoma. About 50% of the patients suffer from this condition. And then another carcinoma is carcinoid tumors. Okay. Other causes could be trauma to the head, infections, certain medications, hypothyroidism, and major surgery. Okay, stress. Most patients remain asymptomatic, and then gradually things begin to manifest. So common signs and symptoms: nausea, weakness, lethargy. This is, again, think about the expanded volume and hyponatremia. These could be the cause of these situations: confusion, depressed mental status, and seizures. And how do we diagnose this condition is where hyponatremia is one, and decreased serum osmolality. Okay, osmolality is less than 270 milliosmol per liter. Normal or increased urine sodium excretion. Inappropriately normal or increased urine osmolality. Okay, increased urine osmolality or a normal urine osmolality. It's difficult to say. Why? Because you're bringing more water back into the system. So now the urine volume would be reduced. So it may appear like you have more salt than normal. Got it? So that is how it may be increased or normal, depending upon how much fluid is being lost. Treatment of malignancy is one approach to treat the condition. A fluid intake must be limited because the volume is already too much. Then the ADH antagonists, some are very specific, like vasopressin 2 receptor antagonist, or just broad antagonists. Hypertonic saline, because the fluid volume is diluted, or normal saline plus furosemide to get rid of fluid from the system. Okay, it's a diuretic, furosemide. Okay, so those are some steps you can take to treat this condition. How does this affect you is where think about careful administration and monitoring of fluids and electrolytes because of the increased volume. Low urine output can demonstrate delayed awakening, or awakening with mental confusion, and then cautious fluid resuscitation with normal saline is another thing to consider. All right, so now we talk about acromegaly. So this is the abnormal condition related to an anterior pituitary hormone, that is growth hormone. Too much of growth hormone in an adult. Okay, in children, too much growth hormone can lead to increased length of the bones, and that is what you call as gigantism. And then too little of it can cause dwarfism, short stature, and hormone replacement is how you could correct those conditions. And then now for gigantism, you can use growth hormone antagonists. Anyhow, now we are talking about acromegaly. This is in an adult, and what we want to consider here is that what are the consequences? You have too much growth hormone, okay? Often caused by a growth hormone secreting pituitary adenoma. So a tumor in the pituitary making too much of this hormone. Male and female are equally affected by this condition. The tumor, as it expands, symptoms include headache, okay, papilledema, and visual field defects. These are affecting the eye and the eye's functions due to compression of optic nerves and optic chiasma. A compression or destruction of the pituitary by the tumor can cause panhypopituitarism. What is panhypopituitarism? That is the condition where all of the hormone made by the pituitary are affected. Okay, as you know, anterior pituitary is responsible for a long list of hormones to be released: TSH, ACTH, LH, FSH, prolactin, and growth hormone. So all these are affected by the compression of the tumor. So that is a possibility. Increase in size of certain body parts and the overall weight gain. Hypertrophy in skeletal connective tissue and the soft tissues. Okay, the bones grow wide, not long, but wide. The tongue and epiglottis are enlarged. Upper airway obstruction. So this is where you need to consider how you would fit the face mask. And exposing the larynx for endotracheal intubation may be difficult. There may be increase in the serum IGF-1 because growth hormone being released in greater amounts, meaning the growth factors it uses to bring its effects would also be increased. IGF-1 is one of those growth factors. All right, some other effects are hoarseness and abnormal movement of the vocal cords. Paralysis of a recurrent laryngeal nerve may result from stretching caused by overgrowth of the surrounding cartilaginous structures. Involvement of the cricoarytenoid joints, this is again in the larynx, can result in alteration in the patient's voice. We already talked about hoarseness, resulting from impaired movement of the vocal cords. Soft tissue overgrowth may lead to glottic stenosis and predispose to post-intubation edema. Cardiomyopathy, hypertension, accelerated atherosclerosis. So there are many tissues involved affecting many systems, congestive heart failure, arrhythmias, glucose intolerance. That's because of too much growth hormone and how it increases blood glucose levels. And that may lead to diabetes, peripheral neuropathy, skeletal muscle weakness, and so on. Here it says paracellular tumor, sella turcica is the space where pituitary gland is present. So somewhere close to that is what you call as paracellular tumor. That's where you have the enlarged sella turcica, headache, visual field defects. Rhinorrhea is a runny nose. So all these are typical. Okay, excess growth hormone causes skeletal overgrowth. So this is because of the tumor effect, and these are because of the growth hormone amount being greater than normal. Skeletal muscle, skeletal structure overgrowth, and then soft tissue overgrowth, connective tissue overgrowth, peripheral neuropathy, leading to carpal tunnel syndrome, visceromegaly internal structures enlarged, glucose intolerance, osteoarthritis, osteoporosis, hyperhidrosis, skeletal muscle weakness are some of the conditions to expect. All right, how do we treat? Removal of the growth hormone secreting adenoma, somatostatin analogs, growth hormone inhibiting hormone or somatostatin is what you need to inhibit the action of growth hormone, or growth hormone antagonist is another option. All right, so that is where we finish the discussion of acromegaly, but we came across panhypopituitarism. So just a little bit about it. Severe shock, because you don't have many hormones from the anterior pituitary. Hemorrhage could be the cause of severe shock. Marked hypotension, again because of the hemorrhage. Decreased secretions by the adrenal cortex, because some of the hormones from the anterior pituitary affect other endocrine glands. One of them is adrenal cortex. Thyroid is affected, ovaries are affected, the testes are affected. Then weight loss, atrophy of the breast, and genitalia are just a few things to list, but there are many more due to panhypopituitarism to expect. All right, this is where we want to stop and pick up from here in the next video, that would be focusing on thyroid hormone abnormalities. Thank you.